Hey folks, Scott Weingart here, bringing you a CV cardiovascular EMCrit WE. Now, a few weeks ago, Trina and I did an episode on electrical storm. All things electrical storm leading up to the need for mechanical circulatory support. And we stopped the episode at that point. This one's a little different. This one is specifically for electrical storm on patients already on VA-ECMO. And this will be of particular interest to cardiovascular intensivists, though, anyone who has an interest in the subject matter may get some stuff out of this, but really this is for a very subset population of the EMCrit audience. So this is for people who are managing patients on VA-ECMO already and what happens when they tip into electrical storm. So let's get right into it. Now we are on part 2.
Let's do it.
All right. Trina, welcome back. This is now part 2 of our electrical storm series here on cardiovascular EMCrit. You're going to be in the driver's seat on this one because there's a lot here and you got to tell me which way we should go. So let's get right into it. Trina, you have a patient, you thought you solved the problem. You put them on VA-ECMO for goodness sake. And now that you're going to tell me we still have to worry about electrical storm, this is just torture now. Who is this going to happen on, I guess is where we start. And then we could go from there.
Especially for this part, I'm thinking of this. If you were the cardiovascular intensivist, yes, maybe the person got put on for electrical storm, but actually, a lot of times, these are actually patients that were put on VA ECMO for a different reason. So maybe it was your post cardiac surgery patient that couldn't separate from bypass. Maybe it was the cardiac ICU patient that has an end stage cardiomyopathy that our plan is to bridge to advanced therapies like an LVAD or a heart transplant. And now suddenly you're thinking, we're on VA ECMO, but you are sitting here in electrical storm. And the question is, how do I approach these patients? Some things are going to be similar to part 1 of the podcast, and some things are different because these patients are very nuanced.
Where to begin?
So I think the best part to begin is once again asking yourself, why are these patients in electrical storm? And we talked about this a little in part 1, and some of the broad categories are the same, but yet there's a little nuance to it. So, for example, if you have that patient in front of you and they're in electrical storm, here again, you're going to look for electrolyte derangements. Typically, we're diuresing these patients, especially post op. So, it's really important to make sure that 1, we are not causing electrolyte derangements. 2, you're looking for ischemia. But here it gets a little more complicated. Maybe this is your post CABG patient. Did a graft go down? Or your patient that's post Bentel, meaning they had an aortic root, valve, and ascending replacement. And maybe when they reimplanted those coronary buttons, they twisted one. And maybe you're having ischemia from that. Maybe it was a cardioplegia catheter that caused damage to one of your coronary vessels and caused a dissection. Or it could just be a supply demand mismatch in the postoperative period. You have a lot of catecholamines on, they have an increased adrenergic response with pain. There's many different reasons, but it's really important here again to have a very low threshold to send these patients to the lab to do a left heart cath and look for ischemia. Just realizing that the etiologies for ischemia have suddenly become more nuanced. Other things that are very similar, you're still looking, are my drugs the culprit? Do I have a prolonged QTC? Things like if you have end stage structural heart disease, you probably know that, and you probably have a pretty good clue in, especially if you see monomorphic VT on someone that has an EF of 10 to 15% that you're bridging to advanced therapies. At least you have a good idea of what's causing your VT. One other thing that I think is really important in this population is this someone that has epicardial wires or a transvenous pacemaker? And did they come up from the OR in an asynchronous mode because they had cardioplegia on board and had almost nothing underlying? And now suddenly they developed a rhythm and you just gave them an RMT phenomenon. I'd recommend that people look at the post because there's very nuanced things that you'll face, especially patients that couldn't separate from bypass that come up on VA ECMO. Maybe they have LV distension that's actually driving their arrhythmias. Maybe you put them on VA ECMO, but this is a patient that ends up with ventricular arterial uncoupling, and actually they end up with significant LV distension that's causing increased wall stress and myocardial ischemia, and hence they have refractory arrhythmias. Or maybe they have VA ECMO and an impella, and that impella is abutting the mitral valve or the septum and causing arrhythmias. So basically what I'm telling you is you're still looking for triggers, but your triggers have just become way more nuanced.
And you make a point in the post that the VA ECMO itself may be the problem here. So tell me about that and how to troubleshoot that.
Oh, you're going to try to get me in trouble on this post. I'm laughing because I need to do a whole podcast on this. But yeah, so there's a lot of discussion. Traditional teaching on VA ECMO, if you look at all the cardiovascular computational models, they are going to say that as you go up on ECMO flows, you have that flow dependent increase in afterload on the left ventricle. And when you look at those beautiful pressure volume loops, you're going to see those PV loops getting narrower as they are shifted upward and rightward, meaning suddenly this poor, weak LV that has impaired contractility is seeing a ton of afterload and it's having a hard time ejecting. So you end up with increased left ventricular end diastolic volume and pressure. And so historically, that's what everyone has been taught. What becomes interesting is when you start looking at those modules, you realize that they're too simplified. They're holding everything else constant, meaning contractility and preload. But you and I both know when we put a patient on VA ECMO and we run them at 4 liters of flow, you are basically rerouting 4 liters of flow that are not going to go through their transpulmonary circulation and get to their LV. So you are actually also significantly decreasing their preload. So on one hand, you're decreasing preload. On the other hand, you're increasing afterload. And so, what wins out is variable based on the patient's physiology. And I'm someone who will flow high. And yes, maybe their maps will go up, but then I will combat that with afterload reduction. It's very common for me to have these patients on a medication like clofidipine so that I can get the most of both worlds. I decrease preload, I flow high, increase oxygen delivery and hemodynamic support, but I also can control their afterload. And so for most of those patients, I can get them to eject and actually keep them at pretty low LVEDPs that are at an okay spot. But if you're not managing your ECMO patients like that, and they end up coming up like some patients I'll see patients coming from the OR flowing 2.5 liters with a MAP of 90, and they have minimal ejection. Those patients are going to end up with a distended LV. And we know as that LV EDP goes up, your coronary perfusion pressure is going down, and you're going to end up with increased myocardial oxygen demand, decreased supply, and those refractory arrhythmias, where the VA ECMO can actually be causing the problem.
Yeah, everything you said there was spot on. And especially the last point that they're all pretending we have no control over the afterload. And you and I have both talked about that we're going to do a separate episode just on this point because it's such an irksome one. We're able to fix whatever afterload increase that we don't want. And so to have a model that doesn't take into account that we have specific arterial vasodilators is just so frustrating. Okay, so now we've clearly assessed and fixed if afterload is the issue and if the VA ECMO is contributing. Where do we go next on this, Trina?
Perfect. So why don't we talk about how, if you've listened to the first part of a thing, we talked about the pillars of therapies. Why don't we jump to the pillars of treatment here and just talk about how they're nuanced in this population? So realize for the listeners that this is not going to be comprehensive like the first one was. So it's important to listen to that one too. Do you want to start at antiarrhythmics?
Yeah, sounds good.
Let's do it. So, one of the things is with antiarrhythmics, we've now just made our lives more complicated. And everyone's, oh no, like it wasn't bad enough. But remember, you just put them on a circuit. So, you've one, increased their volume of distribution. And two, you give them a great way to sequester and absorb your drug. So, what does this mean? Drugs that are lipophilic and highly protein bound, you might need more of those drugs. Guess what? Both amiodarone and lidocaine are highly lipophilic. I'm sure you expected that. Especially for amiodarone, I always tell people you might end up needing a little bit more initially, especially as you're dosing. So don't be shy. I think on the first episode, I said I'm pretty quick to give them their 5 mg per kg. So most people will get 3 boluses pretty quick right away. And here you might even have to consider more. Start the drip at 1 milligram per minute. You can even consider transiently putting it 2 milligrams a minute to try to get them to get more therapeutic effect up front. So that's one thing. Typically, I don't measure drug levels, but one of the things we'll talk about is measuring drug levels in certain of these drugs. Not so much amiodarone. Amiodarone, as we all know, has a really long half life. Typically, we're just more looking for total load over the days and kind of monitoring for therapeutic effect. But unlike amiodarone, lidocaine is a medication that very much in these patients, I am dosing off of drug levels. So here again, my initial go-to, I'm still going to be pushing probably 100 milligrams times 2 and starting their drip at 1 milligram a minute. Unless it's someone with pretty significant ischemic liver injury, maybe I'll start it a little bit lower. Or say I've done a stellate ganglion block, given them a significant amount of lidocaine or something with that. But the big thing to know with these patients is it is really important to get quantitative levels because you really want to be monitoring this because you really can see the neuro side effects and lidocaine toxicity is real and it's very easy to hit that. So I think that's the big thing to be aware of with those two medications. And then we talked briefly about procainamide, and on the first episode, and here it's the same. I think I talked a little bit about my approach is first amiodarone, multiple boluses, start the drip, lidocaine, 100 milligrams times two, start the drip. And if you're still in refractory arrhythmias, moving towards procainamide can be affected by the increased volume of distribution. Typically, though, I'm not really dosing it differently. I'm still classically doing 100 milligrams over 2 minutes times three, and maybe completing that bolus of 1 gram over anywhere from 30 to 50 minutes, depending on how the patient is doing. But once again, I'm pretty hesitant to start them on a drip. And if I'm considering a drip of procainamide, I'm probably stopping my amiodarone. If you are using them simultaneously, you need to be really careful that you're monitoring for QTC prolongation, QRS widening, hypotension, instability, especially on your patients that have renal and liver dysfunction.
Vasoactive infusions is the next item on the list here.
So the thing I love about vasoactives when you have them on ECMO is we can do hemodynamic support with the ECMO. Sure, if you have a patient that is very vasoplegic, you might need some vasopressor support. But my goal typically with these patients is to completely support them with my ECMO flows if possible and try to definitely wean off of inotropes if possible, especially if they are appropriately vented or I have.
Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Them quickly ejecting, and then also try to get off of vasopressors. If I'm using vasopressors, it tends to be a low dose vasopressin or a low dose norepinephrine, but typically I'm trying to get off of everything if possible. And here you clearly have the advantage because you have the hemodynamic support from ECMO.
All right. Now, I know you like to keep your ECMO patients light. You like them walking around. You like them awake. Would that change on a patient in electrical storm? Are you sedating these patients more heavily?
Yeah, so initially, yes, because as we talked about it, that's actually part of the treatment. So for most of these patients, by the time I'm involved, they are intubated and sedated. And typically I'm going to leave them like that with deep sedation until I have them at a good spot from an antiarrhythmic perspective. I probably have a left stellate ganglion block in, and I've had quiescence for a little while. And at that point, then I'm going to consider getting them unsedated and ideally working towards extubation. Here again, I want to make sure that they have adequate ejection on VA-ECMO because remember, when you come off of positive pressure, that does affect the LV as well. And positive pressure can be really helpful for augmenting LV ejection. As I'm coming off of sedation, one of the things that I often will do though is if I don't already have them on it, start some dexmedetomidine because that's you can extubate them to dexmedetomidine, and that continues to be good at hopefully helping to also reduce your risk of reoccurrence of ventricular arrhythmias. Clearly, we don't have incredible data yet. We have some data that is alluding to that. And with the sedate trial coming, I'm hoping to have more data, especially in these awake patients.
Yeah, I think even for a patient who's not on ECMO, it's a good tip that if they were intubated for their electrical storm and you're going to extubate them, that might be a nidus of a big sympathetic outflow. Maybe extubating to dexmedetomidine for any electrical storm patient is not a bad idea.
Agreed. I think it's a drug that we're going to start potentially seeing used first line, especially depending on what results we see from the sedate trial. So it might become part of our algorithm right from the beginning.
Love it. All right, what do you want to say about ICDs, transvenous pacers, and epicardial wires?
So we talked a little bit about this in part one, but in part two here, I think it's important to realize that a lot of these patients, especially if they're post-cardiotomy, are going to have epicardial wires, so typically A and V wires. So first of all, Make sure your pacer's not the problem, like we talked about. Adjust the sensitivity. You should be looking at this each shift to make sure that it's appropriately set. And then, two, remember, you can use this to your advantage. So, one of the things that we didn't talk about with drug therapy is we're targeting our drugs towards monomorphic VT. But remember, especially if you have those patients that have polymorphic VT, torsades, and the concern is that they're bradycardic underneath this, you can also do overdrive pacing with this. So it's really important. Ideally, you're doing that AAI or DDD and not VVI. Most patients don't love being overdrive paced at VVI. Their hemodynamics are typically not a fan. Now, if you have a transvenous pacer in, you're typically just going to have that venous wire, so that's all you're left with. But my big thing is make sure your pacer's not the problem. And remember, you can use it to your advantage, especially depending on the etiology of your ventricular arrhythmia.
All right. Do we need to say anything more about stellate ganglion block that we didn't say in part one?
I think the one thing to think about, and some people bring this up and they say, is it safe on VA-ECMO? Because typically they're anticoagulated, they're on dual antiplatelet therapy, and they're absolutely right in the fact that we don't have data. But what I will say is that the STAR trial, even though they were not VA ECMO patients, I think approximately 67% of those patients were either on dual antiplatelet therapy and or anticoagulation, and they really didn't see an increased risk of complications. And I can tell you in my practice, we will do a stellate ganglion block despite therapeutic anticoagulation, antiplatelet agents. We're doing them under ultrasound guidance, and we really haven't seen an increased risk of complications. But here again, data light zone.
Yeah, but that's the key is if you're seeing the needle and you're not hitting big red and big blue over there, there's not too much that should be bleeding. The problem is these blind blocks then be extrapolated to ones where you're seeing the needle. And obviously someone skilled at ultrasound guided needle localization needs to be doing this if you're doing it on an ECMO patient. It shouldn't be, oh, the intern wants to try nerve block. Let's get them up here. All right. What is next now?
Yeah, at this point, one thing that I do tell people that we guess we didn't talk about in here is we're talking about nuances. When it comes to defibrillation and synchronized cardioversion, you might say there should be no nuances. I think the big thing, though, just to remember is that typically, if your patient needs shocked on VA ECMO, you have a little bit more stability on these patients, and especially if they're awake. Be a kind doctor. Make sure that you are giving appropriate sedation, analgesia for this. I think that's super, super important. A lot of these patients will tolerate these ventricular arrhythmias. You will typically watch them go from a pulsatile blood pressure to flatline. So, yes, you don't want to leave them there indefinitely because you do want them ejecting. We know not ejecting on VA ECMO is not a good thing. And some people will be very symptomatic, but you do have a little bit more time. And sometimes you can actually get them out of these arrhythmias with just pharmacologically rather than having to actually use electricity. So, that's a big thing to remember with that. But otherwise, now I think we're ready to move towards VA ECMO and catheter ablation. You want to
All
dive
right.
in?
Sounds good.
One of the things that on these patients is say you have a patient and you think that the primary etiology of their cardiogenic shock is due to either VT or they have a PVC induced VF, they're having recurrent monomorphic VT, it's someone that has known end stage ischemic cardiomyopathy, or it's VT that's refractory to medical therapies. These are the patients, they're up in the unit, you've had them, you've been working with this, that you're starting to talk about, do we need to go for a catheter ablation? So one side of the coin is that you're already on VA ECMO, so that's wonderful. You have some hemodynamic stability here, so it should make the ablation easier from that perspective. Also, when you compare this to an Impella, one, you have biventricular support, and two, if they need to do retrograde aortic access, it's easier here than when they have an Impella CPN that's transversing the aortic valve. But there are also things that you have to consider when you're on VA ECMO and you're going for a catheter ablation. So things like remember that you can have air entrapment. So we all know, those of us who manage VA ECMO, that we have a large multi-stage drain that's sitting typically by cable. And you want to be careful, especially if you're putting additional catheters in. One, when you're flushing that catheter. Two, when you're putting it in and you're pulling out obturators, you could be lining up perfectly with that drainage cannula and really aspirate air, which will wreak havoc with your circuit. So air entrapment is one. Risk of bleeding is always a concern, especially if you're on anticoagulation and antiplatelet agents, but it's just something to be aware of. Risk of stroke, which is always definitely a complication that can occur with catheter ablation, but especially if a patient's on VA ECMO and they have not great ejection, there's that increased risk of LV thrombus, aortic root thrombus. So classically, they'll like an echo just to make sure you don't have thrombus there already. And then one of the other things to think about is there can be challenges with limited vascular access. So if you've ever seen these patients, you've got a large bore access and one common femoral artery, you've got for your return, you've got a drain in the common femoral vein. Then if it's a patient you also have a vent like an Impella CP or a balloon pump in, you might take up both of your femoral arteries. So that can make it more challenging for retrograde aortic access. Or say you have a patient that's on a more complicated configuration like lava ECMO, where we end up having one typical multi-stage drain that might be sitting bicavally, and then you have another cannula that's actually transversing the septum between your right and left atrium that's also placed in a vein. You could suddenly have used up both of your venous access sites. So it can make it more challenging for venous access, or even if they want to try to map and go through with a transeptal puncture to look at the left side. So just realizing that access can be challenging. Now, for expert operators, you'll say, but yeah, but I have a circuit. I basically have a large vascular access outside the body, which is true. And there's multiple ways of accessing this, probably one of the easiest. So basically, you're going to place a 6 French sheath proximal to where your return cannula is. So it's going to be in the soft tubing before you actually get to your cannula. And that way, once you're done with the procedure, you can clamp off and actually cut that piece of tubing off, reconnect tubing to your arterial cannula, and you never need to switch out your cannula.
Yeah,
So
I love it.
it does make for simple access, and that can be used for caths as well.
I was to say, my Japanese friends, they're like doing all of their caths immediately on after ECPR implantation, right through the arterial line. And they'll leave it there maybe till the next day. And then they just, when everything's calm, then they just switch out that tubing, cut it out and reattach. And yeah, I think it's brilliant. So you have a few pictures and links there on how to do that and with the various configurations. Are you doing that at your place at the Mayo?
So it depends on the interventionalist. We have a couple who will directly access the circuit, and there's ongoing discussions. Clearly, there is pros and cons. And the important thing is that you have skilled operators that are doing that, because anytime you're accessing the circuit, there does come with it its own risk of complications. But what I'll tell you is we've seen a lot of vascular access site, or I shouldn't say a lot, we've seen some vascular access site complications with people trying to access a femoral artery around an ECMO cannula on patients on anticoagulation, antiplatelet agents. So there is more and more conversation going on with, would it be safer to just directly access the circuit? So I think in the next couple years here, it's going to probably become much more commonplace to be just accessing the circuit.
All right. What is left? Have we reached the end here, Trina, or is there more?
I think pretty much the one thing I would say is remember that on these patients, VA ECMO can often be what is being served as a bridge to advanced therapy. So specifically, heart transplant a lot of times in these patients, sometimes at HeartMate 3, depending on the patient. Remember that if they're on VA ECMO, due to the new UNOS heart allocation policy from 2018, that actually places them status 1 for heart transplant, which puts them really at the top of the list for at least 7 days. And then you can always get an extension to try to keep them at the top. And these patients are having pretty good outcomes. So, definitely something to consider and remember on these patients.
Fantastic. All right, Trina, no one could ask for more, but there is more. Check out the post. It's even more information than we've done here. Thank you, Trina. And
Of course.
hopefully by the next time, we'll have some pictures of a very cute and brilliant CV intensivist to be added to the family.
I'm hoping so too. This little boy has went through a lot of ECMO cannulations in the last couple of weeks, so he should know all about it. He'll be teaching mommy things.
That's fantastic.